Our next speaker is Dr. Leslie Walleigh. She is a public health physician with the Environmental and Occupational Health Programs of the Maine Center for Disease Control. She's also a medical and occupational health consultant for SWPA-Environmental Health Project. She will present best practices for health professionals.
Can you hear me? Okay. Well, it's hard to go at the end of the day because almost everything I have to say, someone else has said, or two other people have said, and probably I should have gone before Dave Brown because Dave Brown's solutions are the things that I think that health professionals should be recommending to their patients. Now, where's the, oh, here. So the way I divided up my talk is to talk about historical provider responsibilities in terms of dealing with environmental exposures, environmental disease, and then how that's changed in the era of gas drilling. And you can see this woman in the slide, this healthcare provider is confident, knows what she's talking about, has all the answers. That was before gas drilling. So from my perspective, the provider responsibilities are to be aware that environmental occupational factors may have bad effects on health, and then also understand how individuals are exposed. Now, when I was in medical school, which was in the mid-70s, we had no regular curriculum regarding occupational and environmental medicine. We had 4 lectures on hairy cell leukemia. We had, which I have not seen ever, we had an elective, not for credit, where we could go to a chicken processing plant and go out and see migrant workers. I was in school in California, migrant workers. And back in the mid-70s, so that was occupational medicine. In the 70s, I don't think we even knew there was an environment. There was no such thing as environmental disease, or so we would have thought. So understanding how individuals are exposed, there's a place where a hazardous material starts and is released. If something is hazardous but it's over there and has no way of getting to you, then it's not a risk to you, it's not a risk to your patients. Contaminants have to be able to move through the environment in air, water, the soil, through our food, in order to be an exposure risk. And people have to have a place where they encounter that exposure. And we have to think about, we talk a lot about homes, but it's also schools, playgrounds, places where you might recreate, and at work. And this has already been covered somewhat, the different ways. If something comes near me, but it doesn't get into me, typically we think of that as not being able to have an effect. So inhalation, ingestion, whether it's food or water, and then dermal contact, whether it's something that just irritates the skin or whether it's something that's absorbed into the system. And I chose these pictures in part. I mean, the woman who's out in the field, breathing deeply is obviously can be exposed by air, but she also can be exposed by particles falling on her skin or some kind of water containing or some other chemical falling on her skin. The individual in the shower, as I think Dave and some of the other people have mentioned, the water may itself be contaminated, have chemicals in it that are affecting your skin, but they also volatilize out of water, and so you can be inhaling the chemicals, and that was the reason for recommending ventilation in bathrooms, shower areas, and laundry areas. Now, we don't usually consider these exposure routes, but I think we've had enough talk about this today that I think we understand that there are other exposure routes besides the ingestion, inhalation, and dermal contact. There's also hearing is an exposure route, all the sensory inputs, seeing, smelling, tasting, and feeling. And those are as we've already heard earlier with the sound lecture, important sources of exposure from unconventional gas processes. Now, as providers, we know, this is a very simplistic dose-response curve, but we know that the greater the dose that someone receives, or the more exposure they have, the more likely they are to have an adverse effect from that. Also, the greater the exposure, the greater number of people are likely to react, and the severity of the response is likely to be greater. We also know that some effects of an exposure are immediate. I mean, an irritant effect is often immediate. Some effects are long-term, so an exposure to benzene immediately might have an irritant effect. A long-term effect might be the development of cancer. We also know there are results, medical effects from acute exposures as well as chronic long-term exposures. And we know that different people respond differently. There's a variation in response. There are vulnerable populations, and I think we've discussed that some today already. The elderly, the children, individuals with pre-existing disease, they tend to be more susceptible to exposures. Pregnant women are susceptible to exposures. An exposure at a critical point in pregnancy can have terribly adverse effects on the fetus. And then there's individual susceptibility. And one of the things that has always bothered me is when medical professionals say something like, that can't be bad, it can't be bad for people, or everybody would be sick. And then that's not the way it works. Some people are more susceptible, more sensitive to irritants or other exposures. And my response to that usually is, do you believe that smoking cigarettes cause cancer? And they say yes, most health professionals believe that. Well, does everyone who smokes cigarettes get lung cancer? No. So we see that and we have a tendency to dismiss people who are sensitive. We see that with the with hydrofracking issues. We see it with other kind of indoor air issues. We say that there's the sensitive people, we call them crazy or hypochondriacs, but in truth, some people are more sensitive and more susceptible than others. So when we see patients, we should routinely inquire regarding potential environmental and occupational exposures. What's your water source? What's your heating source? Do you have lead paint in your house? And this is, as I said, when I went to medical school, we weren't really taught to do this so much, but then there became a demand for providers to ask these questions and be aware of this. And unfortunately, I think that with the development of electronic medical records, unless these questions are part of the electronic medical records, healthcare providers are less and less likely to be asking these questions again. The other thing is it takes time to ask these questions, and I know that physicians, nurse practitioners, and physician's assistants are under increasing pressure to see more and more patients, and the people that are controlling their time tend to be people who don't necessarily understand quality medicine. So, and there are forms available which we have online for an environmental history and occupational history. These two that were there were from ATSDR. And we have ones on the SWPA website also. In addition to being aware generally of environmental exposures, providers should be aware of the particular local exposures and what those health consequences are. And then when you see someone, when somebody comes into the office and they have a problem, and you make what's called a differential diagnosis. This rash could be, not this rash, but a rash could be due to measles, or it could be due, to some other viral disease, or, in this case, poison ivy. So you're including environmental exposures into your differential diagnosis. The individual with Bell's palsy, one of the things you might consider is Lyme disease. Could it have been Lyme disease? And then, of course, someone with sinus problems, it could be seasonal allergies, it could be chemical exposures. And we know how to evaluate, or we did know how to evaluate patients for possible exposure-related diseases, allergy testing, blood tests for lead, Lyme disease tests. And then historically, we've discussed prevention measures with our patients. Carbon monoxide detector to prevent carbon monoxide poisoning, insecticides when you're trying not to get tick bites. And then different kinds of treatment for particular environmental illnesses. It's also important that we have resources to consult when we don't know the answers. It tends to be colleagues, government agencies, the CDC, our Department of Public Health, and that we can know how to review the medical literature. So now we go on to the how do we apply these same principles to the era of gas drilling. First of all, you want to know, do you or anyone in your family work in the natural gas industry? And I'm really not going to talk about occupational exposures. We've heard quite a bit about that, but it's understanding that is, as you know, is an evolving field. Then do you or anyone in your family live, work, attend school, recreate in proximity to a natural gas well site or other facility? And you've seen all these same pictures already, I think. There are multiple sites of multiple kinds of exposures, potential exposures. The processing facility is, the compressor stations and processing facilities are ones that are around forever, so, and are potentially high sources of exposures. So be aware of the particular local exposures most likely to affect patients and of the potential health consequences of these exposures. Well, how, as a physician, am I supposed to know about air emissions when the EPA doesn't know about air emissions? And that is just to say there's really not enough data around to know how to quantify air emissions. We do know something more qualitatively about the different kinds of emissions that can come from gas extraction activities. We've talked a little bit about all the ones on the left, and I think that most people know, but in case they don't, that the BTEX is the benzene, toluene, ethylbenzene, and xylene, and we separate those out from the other VOCs because of their recognized hazards. Benzene and ethylbenzene being considered carcinogenic, and other concerns about toluene and xylene, and that the norms are the naturally occurring radioactive material. And in terms of the acute health effects of these different exposures, they can affect multiple systems. The ozone, of course, is not emitted directly, but is formed from the action of sunlight on nitrogen oxides and volatile organic chemicals, but is a strong pulmonary irritant. In addition to the acute effects, diesel exhaust is a recognized carcinogen in lung cancer, and the World Health Organization recently recognized particulate matter in air pollution as a carcinogen. And of course, the benzene and ethylbenzene are carcinogens. So that's the air exposures. Water exposures, the air exposures are, I think, are pretty predictable. You know, if you're in proximity, you are exposed. The water exposures are less predictable than air exposures, and as Dave said, that requires constant vigilance to determine or to evaluate your water. And most people in these rural areas are getting their water from private wells. So, and the potential contaminants there are the chemicals, the radioactivity, and the microbes, which there hasn't been, I don't think there's been enough discussion of, and that's, our understanding is just starting to increase about that, and what the potential is of bringing up not only the chemicals and radioactivity from down below, but also organisms that have survived down there, and what's the implication for us when those are in our drinking water. The U.S. House of Representatives identified 750 chemicals used in hydraulic fracturing. The EPA regulates, based on health standards, 76 chemicals. Now, of course, wells, private wells aren't regulated, but we use the EPA standards for determining whether, if something is below the MCL, the maximum contaminant level, then we consider it safe. If it's above, we consider it unsafe. But then the other, hundreds and hundreds of chemicals that there's no standard for. So if those are detected or not tested for, is the water safe to drink? And these are some of the chemicals that are used in fracking. I think you've already seen a similar slide today, just to give you an idea of the variety of chemicals. And then doing the Marco Rubio thing. In addition to those materials that are introduced in drilling and hydraulic fracturing, I mean, and that's something that someone alluded to, they have to release after 60 days, they have to list the chemicals used in fracturing, but I don't think there's any requirement to list the chemicals used in drilling, which is a whole other group of potential contaminants. Anyway, in addition to those chemicals that are put down the well, they flow back and produce waters that come to the surface contain compounds, as we've discussed several times today, that normally occur thousands of feet below the Earth's surface. And from my perspective, that's probably where they should stay. And this is a picture of, for those of you who are familiar with Lord of the Rings, of Balrog, who lived thousands of feet below the surface. And unfortunately, when they were traveling below the surface, they encountered him. Anyway, so until we know what some of the effects of these chemicals might be, it, as I said, maybe have been a better idea to just leave them there. But these are all chemicals that come back in the flow back and produce waters, and ultimately can contaminate wells through various accidents. We know the EPA is planning to study the impacts of hydraulic fracturing on drinking water resources. And I'm not slamming the EPA. They are understaffed and under political direction to do certain things and not other things. My daughter's a lawyer with the EPA, so that's my disclaimer. This slide is just to recognize that there are impacts on our food sources. This is a compressor station next to beef cattle grazing, and I won't be talking about that. And then I think we've already talked to some extent about the noise, the light, the traffic, both in terms of traffic, in terms of the diesel exhaust exposures, but also the hazards posed by so many trucks on the road. So I want to go on to consider, so somebody comes in with a problem, let's consider the potential environmental contribution to that problem. And I am going to look, for this I'm going to look at what SWPA has found with regards to symptoms that individuals are experiencing attributable to gas drilling. And we did this very conservative process to attribute symptoms to gas drilling. And we looked at about a year of our experience and had intake information on about 50 people with completed intake forms on 36. And these are very extensive forms that talk about exposures, sources, both related to gas drilling and other exposures, symptoms, pre-existing medical conditions, and then there's a whole section that deals with the stress and psychological aspects, which were very pervasive, but which weren't analyzed in this process. So we had completed forms on 36 individuals. We excluded from the analysis the occupational exposures, those individuals who had symptoms, but we couldn't really be sure that they had exposure sources. And then we excluded also the people who had potential exposures but no symptoms. And then we ended up with 23 individuals. We grouped the symptoms. There were 100 symptoms in this form. We grouped them into dermal, eye irritation, respiratory, and the dermal was mostly rash and skin irritation, and most of the rashes were transient rashes after showering. Eye irritation, the respiratory symptoms were like cough, shortness of breath, worsening asthma symptoms. The neurological symptoms were primarily headaches, and the gastrointestinal symptoms were nausea, vomiting, or abdominal pain. And then we got it down to that smaller number of people, and then we only attributed symptoms to those people if there was a plausible exposure, so that an exposure that not only did they have exposure, either water or air in proximity, but there was also some way you could link that kind of exposure to that kind of symptom. That there was a temporal relationship to the exposure, so that means that the person didn't have the symptom before the exposure started, or they may have had a condition but it was worsened, like if someone had mild asthma and then their asthma was exacerbated after a well was drilled near them, then that would count. And we didn't include it if there was an alternative explanation. So if someone had some other disease that could have caused the symptom, and this was mostly seen in neurological symptoms, which is probably why we didn't come out with a lot of neurological symptoms, we didn't include it. So then we ended up with 17 individuals who we felt secure that they had symptoms attributable to gas drilling activities. And you can see these don't add up because, as you're going to see in the next slide, some people had more than one kind of symptom. But the most common was respiratory, and that makes sense because you're talking about a lot of air emissions which are irritants, and irritants lead to respiratory symptoms, cough, sinus problems, shortness of breath, worsening asthma. And then the dermal and GI symptoms were primarily associated with water exposures. And then you can see this is another way, a flip way of looking at it, that there were 8 people that had only one type of symptom, only skin symptom, only breathing symptom, only GI symptom, but the rest of them had symptoms, multiple types of symptoms. And we talk about whether, this is not a case-controlled study, this is not a cohort study, but medical knowledge begins with individual cases and case series. And these are, and that's where you get your red flags and your the light that goes off in your brain that says, something's happening here, we need to investigate this further. And maybe we should, before we go, full speed ahead with this, we should make sure we know what we're dealing with. And then know how to evaluate patients for possible exposure-related illnesses. It's better to identify and reduce exposures than to embark on a fishing expedition to find a chemical in the patient's blood or urine. I've seen too many people that have paid lots of money for urine tests, particularly for volatile organic chemicals, when a better approach is to say, you're exposed, try to reduce the exposure. I mean, one of the problems with testing for the VOCs is that they are so short-lived in your body that you may, and there are other sources of them too, you may get a result that's negative, and that may reassure you that you haven't been exposed when in fact you have been exposed. Or in the case of something like benzene, the common marker that they're using in the urine for testing can be found in other agents. So it could be, it's in some kinds of food preservatives and some types of over-the-counter medications. So if you get a positive test for this phenol in your urine, you don't know whether, first of all, whether you were exposed, if you were exposed to benzene, were you exposed at home, or were you exposed when you gassed up your car on the way to the doctor's office, or were you not exposed at all, and it's actually the phenol showing up because you had a food preservative in something that you ate. So we, at this point, until there's some better marker for exposure that you can say, yes, this was from gas drilling and it's specific to gas drilling and the test is sensitive for that, we're not recommending blood tests or urine tests. And then know how to advise patients to avoid exposure-related illnesses. I should have given my talk first, and then the answer would have been Dave's talk, but that is Dave's talk, so I'm not going to talk about it too much. But just to say again, with the water, I don't think, I mean, I think there's a lot of obfuscation, if I can say the word, about water tests, because just of what I said before, if you only have 76 standards for chemicals and there's 600 potential chemicals that could be in your water, first of all, if, you know, most of them aren't going to be tested for, and what happens when you have 10 chemicals that show up but they're below the level that the EPA would have said was hazardous, but there are 10 different chemicals. I mean, what does that mean? And so I think the lesson is, if you think your water is contaminated, could be contaminated, don't drink it. Don't cook with it. Put a vent in your shower. And then in terms of how to treat exposure-related illnesses, you know, we eliminate the exposure. Well, first of all, it's unlikely that there are going to be new diseases related to gas drilling. These are going to be the same diseases we have already. They're just going to be more frequent. They're going to be more severe. So we diagnose the condition, reduce or eliminate the exposure. We treat the illness or symptoms. And this is really difficult to do in the era of gas drilling. There aren't that many resources to consult. There are not many colleagues that are specialists in this area. We know we can't really rely on the government agencies we might rely on in other scenarios. And as Dr. Goldstein mentioned this morning, we can't always rely on the medical literature. What has happened is there's been somewhat of a vacuum in the medical literature because there have been no epidemiological studies and very few medical reports that have gotten into the literature. And what happens, a vacuum gets then filled by industry literature, industry-sponsored literature, which, you know, there have been a number of studies which have been, you know, falsely reassuring and irresponsible and have managed to worm their way into peer-reviewed literature. So in terms of the medical literature, my advice to health professionals is read the fine print. The following, which was taken right out of that JOEM article, is this research was supported by a grant from America's Natural Gas Alliance, which is an industry, you know, support organization, and the authors declare no conflict of interest. So hopefully, hopefully we're doing better than this, but thank you.
Thank you, and we have some interesting questions here. One of them is it appropriate for providers to connect folks who are ill from exposures to groups that they can become active with? And maybe appropriate isn't the right word. Is it legal to connect? Yes.
I don't know that, I mean, I don't think it's not, it wouldn't be illegal, but whether it's appropriate, I think you have to individualize that depending on your relationship with the patient. That's the way I would put it. I mean, sometimes it's appropriate and sometimes it's not appropriate.
Okay. How about, is there a reason as to why physicians are not speaking out together against the gag orders, in other words, Act 13 in Pennsylvania, prohibiting their ability to treat patients and to speak of proprietary rights that make assessment and treatment more difficult?
I think some providers are speaking out. I know it, and I'm not. I just recently got my license in Pennsylvania, so I've been practicing in Maine. So I haven't started practicing in Pennsylvania, so I can't say that I've spoken to a broad range of providers. But I know that there are providers and organizations like Physicians for Social Responsibility that have spoken out against this. And from my perspective, the gag order is important, but it's really a small part of our inability to appropriately treat people, because you can tell me the name of, if you tell me the name of the chemical, that's still not going to necessarily help me know how to treat the person, and that's all they have to do, and they don't have to post it till 60 days after they've fracked a well. They don't have to post a lot of the other chemicals. So whereas I think it does really restrict providers, because let's say I am treating a patient and I found out what the chemical is. I don't know what that means. I can't then go and consult someone else about it, because then I would be telling them what the chemical was. So anyway, I think it's very complex. I think that part of the thing is that providers aren't encountering the situations where they aren't aware of the situations in which they need that information. You also don't know where, so it's one thing if you have an occupational exposure, because you have certain rules which also have a confidentiality aspect to it, but they're OSHA rules. You are allowed to get a safety data sheet which lists the chemicals, may list something as proprietary, but has to include the health effects. When you're dealing with an environmental exposure, somebody comes to your office, you don't even know who to call to find out. It's like, who do I call? Who do I call at the well site? Who do I call at DEP? You don't even know where to start to get the information.
Call
Anyway.
Dr. Brown.
I don't think he might not be able to help me on that one.
Sorry. What are the major frustrations with shale gas public health that you have experienced as a professional public health person?
I think the major frustration is allowing an industry to proceed without knowing what the health effects are. You wouldn't introduce a pharmaceutical onto the market without knowing whether it's safe and efficacious. And with chemicals, they allow chemicals and processes involving chemicals to become widespread, and then it becomes incumbent upon public health advocates to have to prove that there is an adverse health effect. So I think that's and that's pervasive in our country. In other places, there's what's called the precautionary principle, where if something might be a problem, then you don't go ahead and expose an entire population to it.
Okay, I have one more question. This is very kind of specific. What year did the House of Representatives list the 750 chemicals, and have they moved any further on that?
I think it was 2011 was that publication, and it was a committee within the U.S. House of Representatives that did that work, and I am not aware that whether there's been further action.